Thank you so much, Katie and Erin. Thank you for all the incredible support to make sure the Da Silva Center for Ebstein's Anomaly runs as smoothly as possible. So thanks for all you do. Next speaker is Dr. Nguyen. He is Assistant Professor of Anesthesiology and experienced cardiac anesthesiologist with us at the Heart Institute, and he'll be talking about anesthesia in patients with Ebstein's Anomaly. Khoa.
Thank you, Dr. Kreutzer. Thanks to the Heart Institute and Dr. Da Silva for allowing me to speak today. Like Dr. Kreutzer said, I'm going to discuss a little bit about the anesthetic management as far as it goes for these patients. Before we did that, I don't have any disclosures to announce, but I did want to acknowledge our cardiac team because typically we do most of our work behind the scenes or behind the drapes, as you will. But Dr. Callahan is our division chief, Dr. Fadke, myself, Dr. Blasio, Dr. Adams, and Dr. Stallings. We do our best to try to make sure that all these Ebstein's patients are well taken care of, especially while we take them through all the different modalities that they do before the actual surgeries. But before we get started with what we do here, I kind of wanted to see in terms of the literature what, if anything, was recommended for some of these patients. And what I came across was this first paper on anesthetic management from 1977, so well before the Cone procedure, well before the Starnes procedure, where a 25-year-old patient with Ebstein's anomaly was taken for a pulmonary valve or a tricuspid valve repair. And if you look at the drugs, short of fentanyl, most of the drugs we rarely use in anesthesia anymore. So it tells you kind of an idea of the evolution of what we've done and the medications we have today. This patient basically got droperidol, which is a sedative that we don't really use anymore, and then high-dose opioids, but ended up going to the ICU and extubated there. I'm not sure what the follow-up outcome was. Later on, there was a 2003 case report from the team at Beth Israel in Boston where there was a patient with Ebstein's, 46-year-old, that came with nasal cannula for tricuspid valve replacement. Again, she started to, and since this was in 2003, the anesthetic management seemed to more similarly mirror what we use today. So midazolam for pre-op medication, fentanyl at 30 micrograms per kilo, which is a really pretty high dose for an adult that we don't usually use today, but did well. Required dobutamine and nitroglycerin infusions for separation from bypass. Postoperatively, still did have high filling pressures, and they noted a difficult prolonged wean from dobutamine. In her case, was complicated by heart block requiring a pacemaker. I'm not going to go into the nuts and bolts about the anesthetic considerations as far as generally. Dr. Faith Ross is one of our previous residents who's now at Seattle Children's, and her team kind of summarized this from an anesthetic standpoint. I thought they did a great job. One of the take-home things that were pointed out was the survival now with the advent of the techniques that Dr. Da Silva and Dr. Starnes have come and brought to these patients. The survival has significantly increased, which is amazing. The stress from the anesthetic standpoint was medical stabilization, especially of these really sick neonates of the RV, and trying to minimize changes to the pulmonary vascular resistance, thus minimizing that afterload of the right ventricle, and how common these atrial arrhythmias are in the survivors. As far as our history, I looked back at our STS data, and I want to thank Mary Taylor for giving me this, but the first Ebstein's repair, according to her data, was that Dr. Morrell did one in 2006 where he did an RA application, Glenn procedure with a tricuspid annuloplasty, closed the ASD as well as repaired the aorta. This patient had high-dose fentanyl and Versed as far as the maintenance goes. That's our typical for our neonates. This patient was intubated preoperatively and then went to the ICU intubated on infusions of Levophed and Milrinone. Between 2006 and 2016, Dr. Morel did 14 more cases, and then with the arrival of Dr. De Silva in 2016, the case numbers did increase. So we do have, from what I saw, 102 index cone repairs by both Dr. De Silva as well as Dr. Da Fonseca De Silva. This pie chart shows you kind of a pretty even distribution among the age groups. So about almost a third in the 1 to 6 year age, another 27% in the up to the teenage age, and then essentially what we would consider adults were another 27%. We did do a decent number of neonates as well as infants. And the one take home that I do want to mention as far as the anesthetic goes is because we are trying to make sure we have all the adequate data and preparation prior to surgery. There is a lot of coordination that goes on between making sure that Dr. Al-Sayed's MRIs are done and done well so that they can get the best data to help predict whether or not that RV is going to tolerate the surgery, and then taking them over to the cath lab and having them undergo EP studies and possible ablations, and then finally, later on in the week, having them go to the ORs for the cone procedures. The anesthetics for the EP studies and the MRIs are pretty straightforward. We rely heavily on the IV drugs, midazolam, fentanyl, and stuff like that. But that also goes into the surgery as well, where a lot of these patients don't tolerate a ton of exposure to inhaled agents. The time frame in terms of the anesthetics is hard to describe because a lot of them are from out of the state or even out of the country. So they are here for the week, and so we try to fight the risk between having one long anesthetic versus multiple shorter anesthetics. For surgery, our standard monitors are 2 peripheral IVs, an arterial line, a central line. We do utilize the NIRS to help us manage on bypass, as well as TEE, which I think essentially is standard for most institutions in the United States. Our local infusions that we tend to run are epinephrine, Milrinone, and Precedex, as well as tranexamic acid, depending on whether or not we think that they're at a higher risk for bleeding post-op. From a pain management standpoint, which I think is very important, especially going into the ICU for them, we usually use fentanyl IV. In some of the younger patients, we still do Duromorph cottles, which I find to be just as effective as using IV medications at a lower dose of opioid. But if they're not able to get the Duromorph cottle, then we typically will give a dose of methadone, which can be continued into the ICU. So the average pump times that I reviewed were about 145 minutes. The average clamp times were about 104 minutes. I'm proud to say that 74% of our patients are extubated prior to going to the CICU. I think that speaks to the surgical technique of the De Silvas and how well these patients do post-operatively. I did not find any episodes of complete heart block in these 172 patients, and no mortalities were noted either. But I think that we all feel privileged to be able to work with Dr. De Silva and his wife in these procedures and getting exposure to these patients, from around the country as well as around the world. Has not only helped us become better from management of an anesthetic to just becoming part of this amazing team that takes care of these Ebstein's patients. With that, I don't have much else to add.